Hello, and welcome to Understanding and Responding to Behavioral Symptoms of Dementia. My name is Hamp Ingram. I'm the EMS Training Coordinator for the Franklin County Department of Public Safety, and we'll be discussing dementia and some aspects of it, including but not limited to Alzheimer's disease. So today our objectives are going to be describing the signs and symptoms of dementia, techniques for respectful and effective communication with our patients, techniques for addressing the behavioral symptoms of our patients, alternatives to physical restraint, and identifying and reporting incidents of abuse, neglect, and exploitation. We're also going to be talking about contacting caregivers when we have an individual that's found wandering, especially during an emergency or crisis situation. We'll be provided a reference list of local resources for individuals with Alzheimer's disease and/or dementia. We're going to provide a reference list also of local and national organizations that assist law enforcement personnel with locating missing or wandering individuals with Alzheimer's disease and/or dementia and returning them to their caregivers. So the first part of our discussion is going to be the difference between dementia and Alzheimer's disease. And we kind of lump that in as one thing, but it's actually dementia covers so many different aspects of issues involving the brain, and Alzheimer's disease is just one of those issues. But we're going to cover that here, so bear with me. So what is the difference? Well, dementia is a general term used to describe symptoms that impact memory, performance of your daily abilities and activities, and communication abilities. In most cases, dementia isn't reversible, but many forms are treatable through medication. Now, on the other hand, Alzheimer's disease is the most common type of dementia. It gets worse with time and affects memory, language, and thought. Both conditions can cause a decline in the ability to think and memory impairment, but Alzheimer's can also cause apathy, depression, and confusion. Alzheimer's, unfortunately, is a terminal illness and no cure is currently available. Dementia is a syndrome. Many diseases can cause it. A syndrome is a group of symptoms that often occur together and may have a shared underlying cause. Dementia affects mental cognitive tasks such as memory and reasoning, and it can occur due to a variety of conditions, most common of which is Alzheimer's disease. People can have more than one type of dementia, and that's known as mixed dementia. People with mixed dementia have symptoms of two or more types of dementia. Many people are diagnosed with mixed dementia based on their symptoms, their physical examination, and diagnostic tests. But a diagnosis of mixed dementia can only be confirmed in an autopsy. As dementia progresses, it can have a huge impact on the ability to function independently. Major causes of disability for older adults and places an emotional and financial burden on families and caregivers. Dementia is the fifth leading cause of death globally, and cases are expected to triple over the next 30 years. So when we say dementia, we use it as an umbrella term. It's used to describe a collection of brain diseases and their symptoms. They include memory loss, impaired judgment, personality changes, and an inability to perform daily activities. Well, we see patients like this all the time, elderly patients, sometimes not so elderly patients, who can't remember what they had to eat for lunch, or their not ability to use their judgment well to protect themselves from harm. Sometimes they do have personality changes. And of course, we see families that complain that, my mom or my dad, my grandmother, they're not able to do the things that they used to do. So, under this umbrella of dementia, we have Alzheimer's disease, and its prevalence is 60 to 70% of dementia cases, and is characterized by amyloid plaques and beta tangles in the brain. Symptoms include impairments in memory, language, and visual spatial skills. Then there's vascular dementia. It makes up about 10 to 20% of dementia cases. It's characterized by disease or an injury to the blood vessels leading to the brain, and its symptoms include impaired motor skills and judgment. Frontotemporal dementia occurs in about 10% of dementia cases. It's characterized by deterioration of frontal and temporal lobes of the brain, and symptoms include personality changes and issues with language. Lewy body dementia, about 5% of dementia cases, is characterized by Lewy body protein deposits on nerve cells, and those symptoms can be seen as hallucinations, disordered sleep activity, impaired thinking, and motor skills. And of course, other dementias, they kind of fall under one thing, but they take up about 5% of dementia cases. And those are dementias related to Parkinson's disease, Huntington's disease, HIV, Creutzfeldt-Jakob disease, and Korsakoff syndrome. Now, what exactly causes dementia? There are several causes actually that are included. You're more likely to develop dementia as you age. It occurs when certain brain cells are damaged. It's caused by many conditions, like we said, including degenerative diseases such as Alzheimer's, Parkinson's, and Huntington's diseases. Each cause of dementia causes damage to different sets of brain cells. And Alzheimer's disease is responsible for about 60 to 80% of all cases of dementia. Other causes of dementia include infections such as HIV, vascular diseases, stroke, depression, and chronic drug use. Now, the symptoms of dementia, sometimes you can tell what stage the patient is in just by gathering their symptoms. Early symptoms include occasional forgetfulness, losing track of time, or losing your way in familiar settings. As symptoms progress, they become increasingly forgetful, more confusion, they have repetitive questioning, they develop poor hygiene, and they develop poor decision making. And as those symptoms progress to advanced symptoms, it comes to a point where they're unable to care for themselves. They have trouble discerning time. They have difficulty remembering familiar people and places. Of course, their behavior changes. They develop depression, and many dementia patients at advanced stages become quite aggressive. Symptoms. It's easy to overlook early symptoms of dementia, which can be mild. Dementia often begins with simple episodes of forgetfulness. People with dementia may have trouble keeping track of time or tend to lose their way in familiar settings. Something as easy as going from the house, walking down the street to the convenience store isn't as easy as it used to be, and they may lose their way during that travel. As dementia progresses, forgetfulness and confusion grow. It becomes harder to recall names and faces. Personal care becomes a problem. Obvious signs of dementia include repetitious questioning, inadequate hygiene, and trouble with decision making. And in the most advanced stages, again, people with dementia become unable to care for themselves. They need help with their daily care. They'll have more trouble keeping track of time and remembering people and places that normally they would be familiar with. And their behavior can continue to change and can turn into depression and aggression. Other symptoms of Alzheimer's include an overlap with symptoms of other types of dementia, but there can be some differences. All types of dementia can cause a decline in the ability to think, memory impairment, and communication impairment. But with Alzheimer's, you have greater difficulty remembering recent events, even recent conversations. Patients suffering from Alzheimer's can become apathetic. They don't care about anything. If they have a new great grandchild, that may not be a thing for them. Whereas when they were considered normal, they may have been overjoyed. They also become depressed, and their judgment becomes impaired. And last but not least, they also become disoriented. Disoriented to time, disoriented to place, disoriented to the situation that they're currently in. They can be confused, they can show behavioral changes, and they can have difficulty speaking, swallowing, or walking in the advanced stages of Alzheimer's. Now, let's talk about treatability. In most cases, dementia isn't reversible, but many forms are treatable, and the right medication can help manage dementia. Treatments for dementia will depend on what the causes are. Dementia caused by Parkinson's, Alzheimer's, and Lewy body dementia can be treated with cholinesterase inhibitors. Treatment for vascular dementia focused on preventing further damage to the brain's blood vessels and preventing stroke. Now, as a provider, this is one thing I've always had difficulty with, and that's how to communicate with dementia patients and Alzheimer's patients. Communication with them isn't the same as perhaps you and I having a conversation over lunch, or my wife and I having a conversation driving down the road. The way to approach any kind of communication with an Alzheimer's patient, or less specifically a dementia patient, it takes a little more practice. One thing you need to do is get at eye level with the resident, with the patient, and maintain their personal space. Personal space can be anywhere from 1 to 3 feet. You'll usually figure it out as you talk to them. You speak to them in a low, calm, friendly voice. You don't want to be threatening. You don't want to get in their face, so to speak, and get loud. You want to keep that neutral tone. Talk to them by using their name. If you don't know their last name, it's okay to use their first name. But this is one thing that we should not do with any patient, much less dementia patients, specifically Alzheimer's patients, is not to use what's called elder speak. Terms such as sweetie, honey, girly, sugar, etc., because you want to maintain respect of that person's dignity. I know a lot of EMS personnel who use those terms just because we don't keep up with their name, and we could do a better job of doing that. Nothing grates me more than hearing a paramedic walk in, "Well, sugar, what's wrong with you today?" Find out what their name is, Mr. Jones, Mrs. Smith. If you can't get that, get them by their first name. When you talk to the patient, you need to allow them time to respond. Don't go straight into the next question until you've heard their answer from the first question. Never interrupt them when they're trying to communicate. Don't assume that you know what they want to say. Let them try and get it out themselves. If you have any tasks, can you lift up your arm? Can you tilt your head to the side? Break those tasks into clear and simple steps based on the abilities and stage of the disease. If it's possible, use words from the from the person's native language, and show nonverbal indications of caring and affection. You don't have to come out and say, "I care about you. I hope you feel better. I'm here to help you out." Sometimes just a touch on the hand, or your body language, not this kind of language, or this kind of language, but eye-to-eye contact, arms open, a willingness to help often shows in our body language more than it does in our speech. Now, how do we address behavioral symptoms? Here's some techniques. Of course, they may have internal needs or feelings. They may be in discomfort. Maybe they've soiled themselves, or they're in a position that's not very comfortable for them. Maybe they're hungry. Maybe they're in pain. Maybe they're suffering from an illness that we may not know about currently. And, of course, they may be afraid, because dementia and Alzheimer's is scary for the patient. They don't understand what's going on. And a lot of times they react through that fear, either through delusions or hallucinations. And so we have to kind of bring ourselves down to that level and help them understand that what they're feeling is normal, but in the same vein, don't treat them as such, because they're fearful. Don't make them feel like we're there to overpower them. Sometimes they may have triggers, something as simple as changes in the environment, temperature change in the room, or it may be raining outside. Sometimes a change in their routines can throw disorder in. They may be used to going to lunch at 11 o'clock, and all of a sudden it's been changed to 11:30. They may want to eat dinner and then watch a favorite TV show right after dinner. If dinner times change, they miss their show. That throws their routine off. Noise can be a factor. Large numbers of people all of a sudden can trigger them. Sometimes if caregivers or family members appear stressful, if they appear rushed, this can trigger behavioral issues. Distressed behaviors by another person. Maybe we need to isolate that behavior. Sometimes removal of a person from the patient's room or the patient's area can really help out with their symptoms. Now let's talk a little bit about wandering and elopement. That's when a patient leaves the place where they're supposed to be. Sometimes they'll go for a walk and they may just wander and lose track of time, lose sense of direction. Elopement is just when they walk out the door and for no reason at all just begin wandering off. Most people, believe it or not, are found within a half mile from the nursing home or the home or community that they reside in. Half a mile. They tend not to respond, unfortunately, if they're called to. They may head for public roads or public transportation, and sometimes they will hide. Yes, they hide in any available bushes, storm drains, empty buildings, or even within the residence. Persons with dementia tend to move in the direction of their dominant hand. I find that interesting, finding out if your patient is right-handed or left-handed to begin a search in that general direction, but that is the truth. People with dementia tend to move in the direction of their dominant hand. So what you want to do is search in that direction first, unless there are greater dangers in another direction, such as busy highways, bodies of water, unsafe structures, things of that nature. Now, here are some techniques for addressing the behavioral symptoms, such as aggression. Verbal aggression may appear as obscenities, threats, name-calling. Sometimes patients will use sexual or racial slurs. And then there's physical aggression. They may try to hit you. They may try to kick you, push you, spit on you. If they're able to walk, they may be pacing the floor. They might be scratching you, or they may attempt to even bite you. And I can speak from experience. Many years ago, when I was driving a wheelchair van for a local transport company. I went to pick up a patient at the hospital, and she was sitting in her wheelchair. Her husband was beside of her. Walked in with my wheelchair, said hello, how are you? The husband said hello. His wife in the wheelchair said hello, how are you? I said, I'm doing well, thank you. I'd like to move you from your chair over to my chair. Would that be okay? And she goes, yes, I guess so. She didn't seem thrilled about it, but she said she was willing to move. So I got down and began to move the leg support on her wheelchair when she reared back and kicked me full in the chest and sent me flying back across the floor. The husband was shocked. Of course, I was shocked. The nurse was shocked. And the patient just sat there like, I didn't do anything. Sometimes your patients will be aggressive and you can tell that it's coming. Sometimes they'll become aggressive without warning, without provocation. So you have to be careful and watch at all times. Keep yourself safe. When you speak with your patient, make sure you validate their concerns, their fears. Don't brush them off. Try to reassure them. Sometimes if they have an issue that to them is an issue, but it's not a real emergent issue, sometimes you may have to divert and redirect the conversation. Very important, maintain eye contact. Watch them. Speak to them in a clear, gentle tone of voice. Gentle touch on the hand with residents. They may enjoy that physical contact. That's okay. If they're not keen on it, and generally they will let you know quickly, you may have to resort to another way of contact. Never take their behavior personally. It's not against you. It's rarely against anyone in particular. It's they just act out against anyone who comes into contact with them. Be sure and always explain what you're planning to do, whether you're planning on lifting the leg on that wheelchair, or you're going to take a blood pressure, or if you're going to use a stethoscope or you want to check their temperature. Let them know ahead of time before you do it. And be creative when communicating. If you can use pictures or gestures or demonstrate an object. And I know this sounds a lot like when dealing with a pediatric patient, a toddler, or a preschooler. But sometimes this works very well with patients with dementia and or Alzheimer's. Avoid appearing rushed. Avoid appearing impatient. I mean, unless it's an absolute emergency, take your time. Make sure you assess them completely, but do a thorough job. Don't appear rushed. So those were some of the do's. Let's talk about the do nots. As you can see in the picture, you do not want to stand within striking distance. So you have to make sure and respect the patient's personal space. Don't try to touch a physically aggressive individual when he or she is upset and agitated. And don't argue with the individual. It's not going to do you or the patient any good. One thing you can do is use the talk tactics, and this is something that was developed by the Alzheimer's Association. And when they use talk tactics, they break it down into T for take it slow, A, be sure and ask simple questions, limit your reality checks, but keep eye contact. A person with dementia can easily be agitated or afraid. Make sure that they understand that you are there to help them out. I'm not a fan of restraint. I've restrained patients in the past. I wasn't keen on it because there are so many issues to deal with after restraint. But, you know, if you have to, you have to. But here are some alternatives to having to physically restrain your patient, especially ones with dementia or Alzheimer's. You know, if you can, you want to avoid physical force or restraint. Sometimes you got to get creative to get them to do what you want them to do. You do one-on-one instructions. Are you able to do this for me? Deliver step-by-step directions using very simple language. If possible, relocate the patient to a quiet place. If you're in the back of the ambulance, depending on the situation, it may not be very quiet, but you may be able to dim the lights, turn on the air conditioning, try to make it as relaxing as possible. Use distraction by giving the person a simple task, and make sure that when you're working with your patient at all times, watch them to prevent them from wandering off. Now we're going to talk about abuse, different types. Of course, there's physical abuse causing physical pain or injury. There's emotional abuse, verbal assaults, threats of abuse, harassment, and intimidation. There's neglect, which is a failure to provide the necessities, including food, clothing, shelter, medical care, or a safe environment. Those are things we need to have. If you ever remember studying Maslow's hierarchy of needs, food, clothing, shelter, those are our basic needs. You know, feeling safe, that's a basic need. Try not to restrain or isolate them. Financial abuse, that's a misuse or withholding of the person's financial resources. It could be money, it could be any kind of property, to his or her disadvantage or to the advantage of someone else. Of course, there's also sexual abuse, touching, fondling, or any sexual activity when the person is able to understand, or they're unwilling to consent, or they're threatened or physically coerced. Willful deprivation, that's willfully denying the person medication, medical care, food, shelter, or physical assistance, and thereby exposing the individual with Alzheimer's to the risk of physical, mental, or emotional harm. And yes, there are patients out there who perform self-neglect. And oftentimes it's because of a lack of insight and cognitive changes. A person with Alzheimer's may be unable to safely and adequately provide for day-to-day needs. And they may be at risk for harm, falls, wandering or elopement, and or malnutrition. Signs of abuse, neglect, or exploitation include bruises, pressure marks, broken bones, abrasions, and burns. They can all be an indication of physical abuse, neglect, or mistreatment. If there's an unexplained withdrawal from normal activities, a sudden change in alertness, or an unexpected depression, those can also be indicators of emotional abuse. Bruises around the breasts or genitalia may be a sign of sexual abuse. Sudden changes in financial situations can be the result of exploitation. Bed sores, unattended medical needs, poor hygiene, unusual weight loss, all these may indicate neglect. Belittling, threats, or other uses of power by spouses, family members, or others can indicate verbal or emotional abuse. Strained or tense relationships and frequent arguments between the caregiver and the person with the disease can be a sign of abuse. Abuse can originate from either a caregiver or the person with dementia. A person with dementia can exhibit more aggressive behaviors as the disease progresses, and cognitive function and the ability to reason decline. Now, of course, as EMS providers, as first responders, I should say, whether we're EMS, LEOs, or firefighters, we have a duty to respond to these calls, and we have a duty to report any suspicion of abuse, neglect, and or exploitation. And there's several places we can reach out to do this. Now, of course, locally in Franklin County, of course, you can reach out through the 911 center. They can contact Adult Protective Services. We also have access to the virginianavigator.org. They have many resources to report. Of course, we have Division of Social Services. If you're not sure how to get in contact, you can go to www.dss.virginia.gov and do a search for your local agencies. And of course, nationally, if you want to report an incident, or if you have a concern of abuse or neglect, you can call them at 1-800-272-3900. Again, that's 1-800-272-3900, and that number is manned 24/7. You'll be connected to your state or local adult protective services divisions or to a long-term care ombudsman. Contacting caregivers when the individual is found wandering or during an emergency. Many times you can call APS and inform them of the situation by reporting the incident. Of course, EMS and fire, you can notify local LEOs of a possible missing person to determine if they've already have an active case on the individual. Of course, we can transport the individual to the hospital emergency room for eval unless the caregiver who has legal authority takes responsibility of the individual and there appears to be no medical issues. If you are ever in doubt, transport to the hospital. Now, there is a plan provided through Medical Alert in conjunction with the Alzheimer's Association. It's called Safe and Found. And a Safe and Found plan really is nothing more than having the Medical Alert bracelet. If you look here, you can see 3 different types. The one in the middle plainly explains this patient has Alzheimer's. And the one on the bottom says, this is a dementia patient. My name is William Smith. I'm easily confused, may become agitated. Please call my children. And it lists their names. So there's another reason for us to pay attention when we're looking over our patient and we try to find Medical Alert bracelets. Now these can come as bracelets, they can come as necklaces, they could come as many different forms of jewelry, just like the original Medical Alert bracelets. Now the great thing is the Safe and Found plan through Medical Alert and the Alzheimer's Association is a program that allows for dementia patients to be identified and reunited with their loved ones or caretakers. Participants of the program wear an identification product such as a necklace or bracelet, and providers, us, can call the number on the back of the Medical Alert jewelry for more information and to connect the patient with their loved ones. And of course, if you know someone who is dealing with a family member with Alzheimer's, they can contact Medical Alert online or by phone and register for the Safe and Found plan. I believe it's about $75 a month. But for the peace of mind that it offers, I feel that would probably be well worth it. Other organizations that assist with locating missing and wandering individuals, we have the Aware Foundation of Virginia, and that's at www.theawarefoundationofvirginia.com. Of course, VDM, the Virginia Department of Emergency Management, at vaemergency.gov. The Virginia Search and Rescue Council, if we ever run into a situation where we need to begin a search or a rescue operation for a missing adult with Alzheimer's. That's at www.vasarco.org. And last but not least, Project Lifesaver at projectlifesaver.org. Thank you for watching, and of course, if you ever have any questions, you can reach out to me at the Office of Public Safety, or get online with the Alzheimer's Association website and check out the information they have. Either way, when in doubt, look to find more information. I hope you have a great day. Stay safe. Take care.